All right, welcome back, everybody. Our next presenter is going to discuss palliative care, which most of us probably don't really know much about, and I confuse it, some of us do, with kind of end-of-life care. That's not necessarily the case. So it's highly relevant to people who live with chronic conditions and need support with pain relief, with maintaining daily functions, a good quality of life as your body changes. So here to tell us more about it is Molly Morrill, a certified nurse practitioner with Pathways Hospice and Palliative Care. Welcome, Molly.
Appreciate it. All right. Good morning. Thank you all for having me. Thank you, June, for the invitation to come and share with y'all this morning. My name is Molly Morrill. There is a lovely couple here who go by a last name Morrill with more sophistication. So right back there. My in-laws are Midwestern twang type, so we're the Morrills. So we'll start with that. So as Beth had said, the last 9 years I've been working in community palliative care. I see folks in their homes or in residential facilities. The last 2 years I've been our main provider at an inpatient hospice care center. And so we're going to talk through options for community care, some different community resources, and then we're going to take a deep dive into my favorite topic, which is advanced directives. So a couple kind of working diagnoses we're going to look at. A lot of this is also going to tap into insurance coverage. Some folks are familiar with Medicare, Medicaid. Medicare is care for the elderly. These are folks in the wiserly. This is care for folks that are 65 or north that are part of that program that have registered for Medicare. Medicaid is aid for those with financial need. Those are very different programs. Some folks have both. Some folks have one or the other. This is fancy. Okay. Community resources. I get a lot of questions. What is the difference between home health, home care? What's out there? Are these folks that can come and help in our home if we need assistance? So home health is a skilled level service. As you can see, this involves nursing care. CNAs stands for Certified Nurses Aid, PT, OT, SLP, speech language pathology. This is similar to speech therapy. SLP is kind of the newer term, and social work support. These folks come into the homes, meet with folks there. They are typically geared towards rehabilitation. How do we maintain our activities of daily living? What can we do to help folks be able to continue to shower, dress themselves, get around their homes safely? They are typically 4 to 6 weeks. These are short term, kind of come and go. Again, dictated a lot by insurance. If folks are meeting a plateau with their rehabilitation, they step out. Sometimes they can come back in 30 to 60 days later. There's usually a break. Most of the time, these are covered by insurance. This is third-party insurance and Medicare and Medicaid. Home care / caregivers. This is separate from home health. These folks are typically paid out of pocket. There are some coverages in disability or Medicaid. Sometimes VA will help pay for this depending on the level of disability determined by the VA. These are considered non-skilled services. What that means is these folks are companions. These are caregivers. If morning routine is getting really hard and your partner needs some help with that, these are the folks that are going to come in and help get out of bed, get started with the day. Because you're paying out of pocket, these services can be continuous. You can have home health at the same time. They're coming in and out. Home caregivers are continuous. Palliative care, my neck of the woods. There are community-based palliative care where you go to clinic, and there's also services like mine that come and see folks in their homes, get eyes and ears in there. What's working? What's not? How can we help you to thrive in your current environment? We are goal and value-based care. We can come alongside home caregivers and home health. We're different in that aspect, and we can be congruent with those other services. That's not a conflict. Palliative care is typically paid for by insurance. You may have a neurologist and a cardiologist. Palliative care fits right in there. We're another specialty practice. And as a result, then again, you can also have the skilled care coming in. Hospice care, different goals there. This is when we shift gears from focusing on, a treatment rehabilitation towards comfort, quality of life. Hospice is available to anybody with an estimated 6 months or less prognosis. Unfortunately, the average length of stay in hospice is 7 days. We get really late referrals for folks come in, and when in actuality, folks can have even years of coverage and additional support for their families. You cannot have comfort and rehab at the same time. So if we're gearing towards rehabilitative care, you can't also have hospice care. That part is one or the other. If you have a local area agency on aging, they will often have booklets and information on who is serving in your community and what those agencies are, if you're looking into those resources. So who has heard of palliative care? Yay! All right. So I stole this picture from a hospice agency in Texas. I think it shows really well that they are similar. They're often associated with each other, but they are also very, very different. Palliative care does not necessarily have to be for folks that are nearing the end of the road. They come alongside folks that are dealing with a serious illness, or now we're compounding that with some other issues. We may have FSHD. Oh, we got diabetes. Oh, COPD, and a couple different things going on. That's hard to navigate when you're stacking those issues. So helping folks navigate, what are we doing? What does this look like? What can they do for me? Offering guidance on managing symptoms is a really big piece of this. The benefit of having palliative care come to the home is they're looking at what's working in your current environment. And helping you understand your treatment options. When we're looking at, clinical trials, if somebody says, hey, now we've got this heart issue, we think you might need a pacemaker. It might be nice to sit down with somebody and kind of weigh out, what are my pros and cons? What makes the most sense for where I am with this process? Is there going to be a burden on my partner? What would this look like for them to also have support? Emotional support for caregivers as well. FSHD has some great support groups available. Palliative care can also come in and do family meetings in the home and do some therapy there. So when would palliative care be appropriate? Specific for FSHD, so these are some of the main triggers. Difficulty breathing, fancy medical term is dyspnea. Some folks deal with this, some folks don't, but if breathing is getting more difficult and you're laboring more with that, it might be time to say, hey, who can come in and help me with some of this? Similarly, dysphagia. This is difficulty swallowing. Those are some, that changes what we can eat, that changes nutrition, that changes medication. Changes with mobility and motility. Mobility piece being, are we having, more falls? Is mobility getting more challenging? Motility has to do with the gut. Is stuff moving through? Are we having issues with bowel regulation? The symptom. All right, the symptom management piece for palliative care. Pain, a big piece of FSHD. A lot of you guys are living with this daily. A lot of it is not managed well. How do we help folks to thrive so we can get these symptoms out of center focus and let you focus and enjoy your quality of life and not so much on, it's just too hard to get up today. Pain. Palliative care, some agencies will take over the management and prescribing piece. Some agencies work in a consultative role and say, hey, I'm seeing you in the home. I'm going to work with your pain management specialist or your neurologist or whoever's kind of managing that to make recommendations. Non-farm measures can be a key component of that as well. If you're in a state where marijuana is available and that's been used for medical treatments, what's out there, what's available? Typical main components with that, CBD, used primarily for pain. The THC component is primarily used for folks who need help with anxiety, appetite stimulation, maybe sleep at night. There are combinations of those. Can also be separate entities. I know there's a gentleman speaking this afternoon too on more detail of those options, but knowing where can I go to ask this question? Do I start recreational? Is it worth pursuing the medical side? This is a great place to start. Battlefield acupuncture. Some of you have maybe had acupuncture, the full experience. Battlefield acupuncture is one that deals with a smaller area. There's some folks trained in being able to do this in the home. Where you are, if mobility is becoming more challenging outside of the home. Topical modalities. There is no shortage of creams, gels, transdermal patches, things like that. Would that work for me? Is that something that's appropriate? It's great to troubleshoot with a palliative care provider. Constipation, a lot of medications. This is a common side effect, is slowing down the flow. So some folks would say, hey, can we do dietary modifications to keep the system moving? If that's ineffective, now are we looking at medication management? Things like MCT oil, which is a derivative of coconut oil, sometimes can lube the chute enough to keep things moving. Senna is a vegetable laxative. Sometimes it's partnered with a stool softener to soften and move. What's going to work with what you've already got in play that's not going to conflict with other medications? It's really important to talk about, but there's a lot of over-the-counter agents people don't even know are out there. It's an awkward subject, but it's important. Dyspnea we touched on. This is the shortness of breath piece. Body positioning. If you are exhausted all day and your quality of sleep at night is pretty poor, what do we do to help with that? Are there adjustments that can be made to your bed, to positioning for your caregivers if they're helping you get situated to maximize your sleep? What would it look like to have a CPAP? Is that something I think I could handle wearing at night, or is that not something I think I could handle? Troubleshooting those questions. In severe cases, when folks are using a lot of muscles and are laboring with breathing, sometimes opioids can really help relax those muscles and help people to get better sleep and better quality of life. Dysphagia, this is difficulty swallowing. Are there dietary modifications that can be suggested so folks can continue to get the nutrition they need? Medication review is a really big piece of this. There are some pills that are giant, and it's really hard to get them down. Looking at line item order. Do I still need this? Do I still need this giant calcium bone enhancing pill, or would I rather eat ice cream if I'm going to swallow something? Family support. Watching somebody lose weight as they go through the changes with the body is really hard. How do we support your family to say, where's the push-pull with encouraging people to eat versus letting them kind of guide? This is a really sensitive subject. How do we support families to say, this doesn't need to be a social inhibitor, that we can't ever go out to eat again as a result of this being a source of embarrassment for someone? The social work piece of palliative care, determinants of health. This is kind of a new category in the palliative care realm. This is looking at what are some barriers to folks getting access to care, and what are some of the high-risk things that often land folks in the hospital. Is that lack of financial resources? Man, we could use some help at home. We can't pay for the help. Transportation. We live 2 hours from the nearest clinic. What can help with, can we get a better telehealth setup? Things like that. Serious illness counseling. This is separate from counseling for like anxiety and depression. This is specific to chronic illness. This can be very real with grief. 6 months ago, I could do this. I'm struggling to do this now. How is this impacting my wife? I really need somebody to talk to about this. This is a really big component for the palliative piece, dealing with disease-related counseling and support. And then also community resources, knowing what's available in my area. Okay, care environments. I get a lot of questions on this. The difference between assisted living facilities, skilled nursing facilities. Assisted living facilities, a lot of folks don't necessarily know this. If you have standard Medicare or third-party insurance, that does not pay room and board in an assisted living facility. It is typically paid out of pocket, usually like monthly payments. Medicaid can help pay in some cases for assisted living facilities. Places that accept that level of that financial program, few and far between. As you can imagine, the need is far surpassing what we have available. PACE program, this looks different in each state. This is kind of a dual Medicare, Medicaid program for folks that are north of 55. It is income-based. The threshold for that varies by state. So some states have, higher financial acceptance, some it's a lower, income rate. But these can also help with payment for assisted living facilities. They also have tiered levels of care. You have your standard room and board fee. If they're helping with medications, that may be an extra amount per month. A typical understanding with assisted livings is that folks can transfer themselves into a wheelchair or to a walker and transport down to, say, the dining room or a common area. Folks that require full assistance with those transfers, we're going to be looking more in the skilled nursing realm, which is the other side. So there's two wings to skilled nursing facilities. One is rehab, and this is folks that are in for a tune-up. What can we do to get stronger? And to qualify for inpatient rehab, you have to have a qualifying event, which is 3 nights in the hospital. And then if it looks like, hey, we could use some help before we go home, folks can go to inpatient rehab. Medicare will cover up to 100 days a year, so long as folks are meeting those rehab potential goals. If it plateaus, Medicare says we can't stay in an inpatient rehab situation. The other wing of that is long-term care. And again, unfortunately, this is typically paid for out of pocket. Standard Medicare, standard third-party insurances do not pay for room and board in skilled nursing facilities. Often folks will have to spin down and qualify for Medicaid to pay for that Medicaid long-term care. If you have a long-term care insurance policy, some folks have them, some folks don't, they're kind of pricey. Sometimes they will say, you gotta prove it. You gotta pay up front the first 30, 60 days, and then long-term care insurance will pick up and cover the bill. All right. Ooh, it's a little harder. All right. My favorite topic, advanced directives. This is really giving the gift of guidance to your loved ones. So what is it? There's 2 main components of an advanced directive. The map, which is what are my medical wishes? Your navigator. That's who's going to help me carry those out. Facts about advanced directives. 80% of people say, hey, that sounds great. We should definitely do one. Less than 35% have actually put pen to paper. Has anybody here made one? Yes! All right, we're going to bump that number. We're going to go higher than 35% with this crowd. So typical when we're talking, these are really sensitive topics too. When we're looking at out-of-hospital CPR rates, most of us are not spending our lives in the hospital. We're out in community. We're in our homes. We're living life. The success rate for CPR in the community is 11%. Less than 9% for a neurologic recovery. Those numbers aren't great. If we're compounding that with other health issues, heart failure, COPD, with FSHD, with these issues, that success rate is lower. It's really important to have those conversations with family. What would I want when I get to this stage? And if you have ever watched, ER, Grey's Anatomy, the popular TV shows, whenever they do CPR, the success rate is 100% within 20 seconds, and then you gallivant off to the linen closet with your savior. This is not reality. Looks a little bit different than that. We don't always get to choose the hunkiest EMT. So the first piece of this, medical durable power of attorney, this is alphabet soup, MDPOA. If you are able to make decisions for yourself so long as you can, you're going to be able to do that. If you've ever had surgery, you know that right after surgery is not the time to be making any serious decision making. Most of us, as we are nearing end of life, it will be more difficult to weigh out what are my risks, benefits. Some of you have been with family members where this gets kind of tricky, and knowing, okay, if I'm not in position to make those decisions or someone else deems me that, now the MDPOA picks up. Now I need my helper, my navigator. Their job is to advocate for your wishes. If you have a very emotional family member or partner that you think, I don't know if they'd be able to do this in the moment, maybe that's not who you pick as your first person. If you have 7 kids and the oldest one lives 3 states away and your youngest is in your area and they're taking you to the medical appointments, maybe it makes more sense to pick somebody that's familiar with what's going on and can really speak to what you guys are talking about over the dinner table or after those hard appointments. The great thing with this, it does not require a lawyer. MDPOAs can be done anytime. I've got sheets to do it now if you want some homework in your hotel room tonight. Or on the flight home. These are often done even in the hospital. The medical decision maker can be different than financial and general power of attorney. Those, I highly recommend a lawyer for those when you're dealing with finances and assets. You can have your daughter be this and your son be that. You can have totally different folks serving in those different roles. Yeah. Oh, excellent question. Okay, so the question was, would that be accepted in different states? Most states are going to recognize, if not all, if you have a Colorado form saying It is my wife making my decisions, and y'all are on vacation in Hawaii. Your wife is still making decisions for you there. Life partner. So we're going to get into that. So yeah, great question. So listing agents. Usually I recommend folks list 3 different people. You may say, I want my sisters to do this. I've got 3 of them. I know they're going to know. That's assuming they all agree. Some families, that may not be the case. So list in priority who you want to have. They're going to go to person 1 first. If they're not available, they're going to go to person 2 and then person 3 with that. The importance with these forms, they can be revised at any time. If you have a loved one, don't look at your spouse, who may be dealing with memory issues, or a parent, and you're seeing some cognitive changes or maybe some dementia going on, it might be time to consider changing. If dad's doing pretty well and mom's struggling over here, it might be time to revise. Who's the decision maker? So we're not putting a compromised person in the position where they have to carry out a power of attorney when they can't, maybe weigh all the risks and benefits of those options. The medical power of attorney expires at point of death. It is functioning as your navigator, and when you are more, it is no more. So it is not needed. The financial pieces will continue on with whoever you had selected to deal with your assets. I included the website at the bottom here. Each state's kind of making a push for this. This is a really big deal. This is the Colorado link where you can just go on and type your name in and who you want, print it out, sign it, and you're good to go. The map on the right side, which may be hard to read, this shows if I don't do this, now what? As you can tell, lots of agreement among the states about who is next of kin. This is all over the place. So some states will recognize domestic partnership. Some states won't as a next of kin. Some states will recognize gay marriage and gay partnership as somebody that can make those decisions. Some states don't. So if you don't want Aunt Sally coming in saying, by golly, plug it all in, make the form. Did that help answer your question? Okay. Okay, the other piece of this, that was the navigator role. Medical directives, this is the actual form piece of it. Some of you may have heard of these forms. They're usually on hideously neon colored pages and they go on your fridge. If you have a nosy aunt, you can fold it in 4ths and kind of tuck it on the side of the fridge so that your health business isn't out on display. But they typically go on the refrigerator so anybody coming into the home knows what your wishes are and we're not over or understepping your desires. These are the most forms in some state, post forms. The most forms looks a little bit like another word. DNR directive falls into that. 5 wishes. I actually have a bunch of copies of these too that I brought that are blank. So see me after if you want one. And then I also have, these are the Colorado-based ones, but can be, again, used in other states too. This has a little bit more detail on what you're looking at. If you want copies of these to complete, please, by all means, come and find me. I've got plenty to spare. And living wills. This is also included in the little blue book. There are legal implications. If you make your decisions, you are protected under the Patient Self-Determination Act. That being said, if you've ever gone into rehab or the hospital, they're always asking, do you have an advance directive? I love that that card was included in each of the bags and it says advance directive and POA. I love that. It's so important to have these forms done. And you are protected. Your rights are protected. So if you've said, these are what my wishes are, your brother can't come in and toss that in the fire and say, on second thought, he wants to be on a ventilator for life. You are protected. What you have chosen is protected and will be carried out. The last thing I want to cover, real sensitive subject, is medical aid in dying. I get a lot of questions about what is this? What does this mean? There are 10 states listed, plus Washington, D.C., where this is legal. The old terminology for this, physician-assisted suicide, is a little bit archaic. This isn't done out of suicide or profound depression. There are guardrails around who can qualify to get medical aid in dying. Typically, it's folks that are estimated having 6 months or less of life if their disease continues the normal trajectory. You may notice that's similar to hospice. You can pursue medical aid in dying and beyond hospice. Highly recommend it, because now you have chaplain, social work support, music therapy, volunteers surrounding you and your families. You're going through that stage. So it is not just for folks that are dealing with really, really hard mental illness. It actually has to be physical end of life to qualify for that. I included the website on here for Compassion and Choices. They're a great place to start. There is never any harm with gathering information, even if you're saying, I don't know if this is something I would pursue or not. I don't know where this bumps with my spiritual beliefs. Never hurts to have information out there. So I think that was it. Woo. There we go. All right. Thank you. Resources.